as we talked in the pacing nomenclature, usually have 5 different letters, but we usually it's the most common is 3 or 4. So the first one, as we said, is the chamber paced. The second one is the chamber sensed. And the third one is the response to sensing. And the fourth one is the rate, whether you need rate adaptive or none. So if it's none, you usually just keep it blank and you just go with the first 3 letters. So in terms of the pacing modes, it depends also on how many chambers are involved in the pacing. So if it's a single chamber pacing, so unlikely you'll have dual. So you'll only be able to name one chamber if it's a single chamber pacing device. So most commonly is ventricular pacing is the most common type of single chamber pacing device. You could also have atrial pacing only if you have an isolated sinus node dysfunction or sinus node syndrome with an intact AV conduction. So for the ventricular paced is the most common used. The reason we use it is because it's only a single lead and it protects against dangerous bradyarrhythmias, so ventricular bradycardia of any cause. And all pacing devices and ICD devices have the capability of pacing BVI only. So, and the most common one you use is usually for atrial fibrillation and slow ventricular response, or atrial fibrillation with long pauses. Okay, so I had the ECG. I showed it last time, but when I want to read this ECG. So I'll start picking. So I'll go alphabetical. أول شيء أظن عبد العزيز السيد. I'm not sure.
أي واحدة دكتورة.
So this ECG.
Yes. So the question is what type of
so if you were given this ECG on the exam,
yes,
what are you gonna label it as?
So this what I saw, there is pacing the third beats. No, first and the third beat.
Sorry. Okay, go for it.
Again. Which one?
So no, because I accidentally forwarded the slide. So you were talking about this ECG.
Which one?
Sorry, you can't see.
لا واضح بس بيتكرر معايا different ECG.
Let me stop share and I'll share again عشان يطلع معاكم. Okay, this ECG.
Okay.
So how are we going to read this ECG? On an exam, to someone over the phone?
So what I saw there is a paced ventricles. Not sure. So only spiking I can see before each QRS. So this should be ventricular pacing. And that's what I saw.
So you're saying this is ventricular pacing.
Pacing.
So, okay. Anything about the atrium?
Nothing. If I think it's single lead.
So So there are two components for reading ECG. Is the kind of the underlying rhythm. So you need to see if there is any underlying kind of what is the atrial beat? If you have any ventricular beats, how does it look like? If it can't be AV conduction problem, you need to explain it. And then you go to the pacemaker section. You try to figure out, is it the single, dual, and how the pacemaker is functioning. So there are two components here, the regular reading of the ECG and the pacemaker. So when you read the ECG, so you read it as a normal ECG, the rate, rhythm, and you go on. So the rate seems to be irregular. Let us say around 70, 80 beats per minute. So a rhythm, you're not sure if it's sinus. You don't see any regular atrial activity. صح ولا لا?
Yes.
So there is some noise in between, but it doesn't seem regular. So you might actually think there might be either sinus arrest or maybe atrial fibrillation. So you have to comment on that. The third is that you don't see any intrinsic QRS. All we see is paced ventricular rhythm. And based on that, it seems that the pacemaker is functioning in terms of pacing as normal pacing, but you can't assess the sensing of the pacemaker. And you're not sure if there is it's functioning as a single, but you're not sure if it's a dual. So if we're gonna say, I would say this might be atrial fibrillation with paced ventricular rhythm, normal capturing, can't assess the sensing, and most likely it's a single chamber pacemaker. So when you explain this one to someone, you know, kind of you got all the points together. هذه كمان we've talked about it last time. Someone wants to.
Sorry for
تفضلي.
interruption. Yes, Dr. I have a question. Why we cannot assess here? Yes, we cannot assess the if sensitive or not.
Okay.
Sensitive.
So what if you have a ventricular on-demand pacing? What does sensing show? So, for example, how do you sense what does sensing does, and how does sensing work? You see an intrinsic rhythm, صح?
Yes.
That's what sensing is. So you see the amplitude of the intrinsic rhythm, صح ولا لا?
Yes, exactly.
Okay. So ما في any intrinsic rhythm.
Intrinsic
So
rhythm of the ventricle, you mean, صح?
exactly, no, because it's sensing in the ventricle. The lead is in the ventricle.
Yes.
So it's going to sense and pace the ventricle. Here we have pacing. So the pacing is to deliver an electrical signal, impulse, and generates an action potential. And this is what's happening. There is an electrical impulse and there is the QRS. So we know about the capture. The sensing means that if there is any electrical signal happening within the ventricle, the device is going to see it. So now we're not sure is a device saw anything ولا لا لأنه everything here is paced ما في intrinsic. So I can't respond. I can't say anything about the sensing. صح ولا لا?
Okay.
To assess the sensing, there has to be something for the device to sense, whether intrinsic signal, whether it's a noise from outside. And based on that, the device might behave correctly or incorrectly. Well,
Okay.
مفهوم فهمت؟
The next, the second point, I believe, if dual or single برضو ليه ما نقدر نعمل assessment ليها؟
لأنه نفس الشيء احنا قلنا the device how does it function? It senses and it paces. صح؟ So we don't know if it's sensing the atria, but at least it's not pacing the ventricle, it's atria. So there might be, this patient might have paroxysmal atrial fibrillation. And this time he's in atrial fibrillation with ventricular pace. The next visits, he might be in sinus rhythm and have sinus rhythm with AV conduction. And sinus rhythm with paced ventricular conduction, that is sequential AV pacing. So at least this time, I don't know if he has any evidence of sinus of atrial lead functioning, whether by sensing or by pacing.
اوكي تمام واضح. ايوه
Okay. Next online عندنا عبد الله الصيعري. ما أعرف إذا عبد الله سامعني ولا لا.
أهلين دكتورة.
يا هلا. Do you want to give it a
Hey.
shot?
Yes, I will try. There is basing at atrium before the P wave.
So فين بالضبط؟
At the Q exactly.
So
Should be said.
أرجع مرة ثانية أرجع مرة ثانية أنا. So start with one lead. يعني أسهل لك أنت just to follow a rhythm strip. Follow
Okay, lead
it,
two.
and then you could go into the other. Sure, you will تمسك lead two and follow it as a rhythm strip. وبعدين you could use the other leads for extra information. But it's always useful if you just want to look at the rhythm, follow one rhythm strip, and then you could divert into other things later on.
Okay. So there is pacing before each QRS.
There is spacing before each QRS. That's good. And what is the response to the pacer spike? So there is a pace spike, صح?
Yes, yes.
And then there is a QRS. So there is pacing and there is capture.
Yes.
Ah, okay.
Yes.
And then
yes. I thought PPT.
What happens? What happens towards the middle of the rhythm strip?
Become no pacing. Become no P wave QRS without pacing.
There is a pacing spike here. There is a pacing spike here. There is a pacing spike here. There is a pacing spike here.
Okay.
There is a pacing spike here. There is a pacing spike here, صح?
But the next no spike.
Okay. Let's stop here. لأن ال QRS هنا كلهم is the same, صح?
Yes, yes.
بس ال QRS here مختلفة.
Yes, that is different.
So what is this?
Yes.
Okay, we'll move to the next beat.
Okay.
لأن هنا ما في pacing spike.
Yes.
So what is this?
Normal QRS.
So this is the intrinsic QRS.
Yes. Okay.
Or intrinsic ventricular beat with a right bundle branch block morphology. So هذه شبه هذه صح؟
Yes.
if we're not really sure, look at the other rhythm strips. V1 هذه شبه هذه.
Yes.
هذه okay يمكن شوية the R is a little bit smaller. Go up to V3, V2, V1 is the same morphology.
Yes. Look.
So هنا في pacer spike. This is not giving you this morphology, it's giving you the
Another morphology.
intrinsic morphology.
Yes.
So anatomic pacing, it did deliver an impulse, but there was already an intrinsic heartbeat, صح ولا لا? So
Yes.
they both happen at the same time. So the QRS is not a result from the pacing. So it's not fusion between the pacing morphology and the intrinsic QRS. It's a pseudo fusion. So it's just happening exactly at the same time. So the pacing didn't work and the intrinsic morphology took over. So here is the intrinsic, and then when you follow, there is a pacer spike QRS, and continue on. Okay, so the question, what is the atrial rhythm? Because we're talking about an ECG now. So what is the atria?
No, I failed. No
Oh,
B wave.
Hina, I can't really say. Okay, when I go here, there is something here, and there is something here. And especially in the second one is more, you can
Yeah,
see it
here
a
is
little
the
bit
clear.
more. Yeah. So and there might be a sinus activity, lakin you can't see it in the rest. So this patient might have sinus node dysfunction. So there is intermittent sinus node activity. Okay.
Okay.
Doctor, can I ask?
Sure, go.
The V1 show that is RBB button. Is this CRTD?
So this is not paced.
Okay.
Neither is this
This
one.
Uh-huh.
So I agree with you. If you're getting an R wave in V1 with that paced, there's a pacer spike before that. So you want to think about left ventricular pacing. Lakin this is an intrinsic QRS. This is not the pace QRS. So the pace QRS, you could actually see it the one after. So it's a little bit negative here.
Okay. So the type of pacemaker now, هو VVI ولا DV? Because there is no atrial activity. هل هو AFib with VVI?
So we're still working on that. لسه ما وصلنا لهذا
اوكي.
الجواب.
شكرا.
عفوا. So Abdullah?
Yes, معك دكتورة.
Okay, so we're talking about the sinus. There might be sinus bradycardia in Shifna, some
Yes.
atrial activity here, so sinus node dysfunction. So the second is the pacemaker. So we said there is pace and there is good pacing, good capture. So there is the second pacemaker function is the sensing. So how would you assess the sensing here?
V attentive.
Okay, so Yani, if you sense the ventricle, what are you going to do? So how does the pacemaker behave when you sense the ventricle?
Inhibit.
Exactly, so it's going to inhibit the pacing. So do you see any evidence of that pacemaker function?
No.
We'll go back again. So lead to, this is the intrinsic rhythm, صح?
Yes.
Okay. So if the pacemaker did give an impulse over here, the next given impulse should be probably around here.
Yes. Yes.
لكن what did why there is no pacing spike over here?
Because the inhibition.
Because what?
The inhibition.
Exactly.
Inhibitor.
So there should be a spike over here. The pacemaker already sensed that there is an intrinsic QRS activity. So it inhibits the pacing and resets the counter. So instead of, so over here, there's already intrinsic. So if it's programmed at 60 beats per minute, that means the next beat should happen after 1 second. And you will wait for this 1 second. And then over here happens the spike. So pacemaker, RV lead is functioning well in terms of pacing and sensing. صح ولا لا?
Yes.
Okay. So السؤال اللي بعده, is this a single or a dual?
Single.
ليش not dual?
I don't see any pacing before the atria, before the beat.
Exactly. So إذا عندنا some sinus node activity here, that means this is not atrial fibrillation, but the device should be able to pace the atrium before it paces the ventricle. صح ولا لا? And you don't see that evidence over here. Over here, you're not sure if it's sensing the atrium or not. Like if it's sensing the atrium and then paced, okay. Sensing the atrium and then sense the ventricle, it's okay. Like you would imagine that there should be an atrial activity before the QRS إذا كان في paced, إذا كان في atrial rhythm, because usually it's either sensing and inhibits, and if there is no signal, it should pace. So we don't have any evidence of any atrial lead activity. So most likely it's a single chamber device. Okay, next. I'll just skip this one. Someone wants to take this? Next on the list, عندنا عبد الرحيم.
Yes. I could see different two morphology that is being paced, both of them, and the pacing is in the ventricle. One of the beat is not being paced, which is the fourth from the left.
Just to be together, خلينا نمسكها one beat at نمسك الرhythm strip and we'll move forward one beat at a time بدل ما نقول كذا اثنين كذا اثنين, and then we'll summarize what we found.
Okay.
So go for it.
So let's take lead 2. It shows paced rhythm, the first 3 beats, and the fourth is not paced. There is no spike, and it has a different.
So خلينا نبدأ. فإذا أول 3 beats عندنا pacer spike.
Yes.
وعندنا wide QRS.
And I cannot see.
So this goes with pacing delivery of impulse and capturing of the ventricle. So it could comment on the ventricular capture, صح?
Yes. And there is no atrial activity.
Okay. So atrial activity, continue following the whole rhythm strip.
Yes.
You don't see an organized atrial activity, if you want to say that. If you follow the rhythm strip, you're going to see a lot of disorganized atrial activity.
Yes. When I follow the rhythm strip, there is one single that is not paced and 2 that were paced with different morphology.
واحدة واحدة. So خلينا الatrial هناخده آخر شيء. So we'll talk about the ventricular. So we have 1, 2, 3. And then what is the fourth one?
It's intrinsic.
Okay. بس احنا عندنا pacemaker. What the pacemaker should do?
It should pace it.
It should pace.
Yes.
So why it's not pacing? You said there is intrinsic, صح?
Yes.
طيب, how does the pacemaker know that there is intrinsic?
Well, there is no P wave before that, or unclear P
Just
wave.
ignore an atrial activity. So now you have a ventricular pacer at least. So there is pacing, spike, and capture, but the fourth one, there is an intrinsic activity here. صح?
Yes.
So if you have a pacemaker, why did this pacemaker didn't fire here?
Maybe it's malfunctioning or failure to sense.
So failure to sense, اشرح لي إياها شوية, ما فهمت عليك when you said failure to sense.
يعني إنه pacemaker once this intrinsic QRS came, it was not sensed by the pacemaker to be paced.
Okay. أنا ماني متأكدة إذا أنت فاهمها صح وأنت you're not able to say it. بس هو the pacemaker function is to pace all the time. Okay. بعدين it gets an order based on the sensing that it does.
Yeah.
بمعنى, this is a ventricular pacemaker, so it's going to pace all the time. لكن in a VVI setting, the second V is the sensed one, and the third letter, it's what's the sense one is going to give orders to the first letter. بمعنى, when you sense a V, you're going to inhibit pacing. So this is how the pacemaker is functioning. So the first one is all the time,
Yes.
and it gets its order from the second letter, from the sensed one. So if you're going to sense something, the pacemaker, the device is telling you, okay, I'm going to inhibit pacing.
Yes.
Okay, so now it's pacing all the time for the first 3 beats, صح?
Yes.
And then, oh, there is a sensed beat. It gives an order to the pacemaker to inhibit pacing. And that's why you don't see any pacer spike over here. And then it resets the counter, and then, okay, I'm pacing again.
Paced again.
But now the QRS is a little bit different.
Yes.
And if you look at the QRS here, it's mostly positive. And if you look at the QRS here, there is a small r and then an S. صح?
Yes. In the negative as well.
So it doesn't look exactly like the intrinsic and doesn't look exactly like the paced one. So what do we call this one?
Improper pacing or not delivered pace.
So there is a pacing spike, and it's not totally wide, but it's not totally normal. So it's a fusion between the native QRS and the pacing spike, or the captured ventricular. And then we continue, you have pacing, 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 pacing. This is a
Native.
sensed beat or the native beat, and this is another pacing. So هذه انفهمت ولا اللي هم الفيوجن بيتس ولا لا؟
ممكن تعيدينها يا دكتورة إذا تكرمتي؟
Fusion beats seems that the native PRS happened at the same time of the pacing. So when the part of the myocardium captures from the pacing, it will fuse with the electrical signal that is also generated from the native PRS. عشان كده it gives you two different morphologies. So it's not similar to the native because the myocardium activation has a different pathway, and it's not totally paced because the pace also has a different electrical pathway to go through the myocardium. So that's why it gives you a fusion between the native and the pacer morphology. فهمت ولا ما فهمت؟
Yes. Can we say from the pacing spike itself, because it looks smaller than the one in the previous, or the three first QRS complex and the latter QRS complexes?
So the first one seems to be kind of a wide QRS that is consistent with a capture ventricle from the pacing. لكن صح, when you go into the middle ones, it's narrower. So it's not totally paced. There is something else happening. So most likely there is a fusion between the paced and the intrinsic.
What about the
So that's why. So, and now you tell me, what about the atrium?
The atrium? I could say that before the first paced beat, اللي هي the 6 from the right, there are 3 P waves.
So which lead are you talking about? بس عشان نتأكد.
Lead 2 and also V1. It's clear in both of them.
So yeah, kind of, okay, if you're looking at lead 2, there is some atrial activity here. There's a little bit of atrial activity here. It doesn't seem to be organized. لكن بس عشان في noise, let's move on and go to something else. So if we go to V1, you could actually see a very nice atrial activity. So here is a little bit positive, but then TG here negative. Here is very sharp negative. Here is more wider negative. Here you go, it's a little bit positive, positive, then negative. So there is multiple morphology and doesn't seem to be organized. So I would call this atrial fibrillation, actually. So in atrial fibrillation and a ventricular paste, this device, is it single or dual?
Single.
Are you sure?
Yes, I am sure, because there is no there is AF.
The absence of evidence doesn't mean the evidence of absence. So it's behaving as a single chamber device. Most likely it is. Never be sure. So here, there is no indication that there is an atrial lead activity, but it might be because of paroxysmal atrial fibrillation. So during AFib, the atrial lead is not working, but there might be an atrial lead there.
Okay.
So, but it's because it's something we call mode switch. هتكلم عنها بعد شوي. إنه for the device, okay, it's going to behave like a single chamber device until the atria goes back into sinus.
دكتورة طيب يعني ما بالنسبة this ECG or base ECG, is this considered normal or there is something abnormal in the pacemaker since we have a fusion beat?
So fusion, you could see it normal, لكن إذا كانت too much يعني مرات the patient feels it. بس يعني it doesn't, there is no harm from it. We could see it a lot. So the idea in general, we want to minimize ventricular pacing in general. So you could try lowering the rate a little bit to avoid fusion. So to avoid unnecessary pacing. So, but otherwise, not really. There is no danger from it. So because you have normal capture, normal sensing, and there's no other kind of abnormality here. So I wouldn't worry
Okay.
about it. Next. Okay. So زي ما قلنا من الأول إن a single chamber device you could place the ventricle or the atrium. We saw examples of ventricular pacing. We could also do atrial pacing. So as we said, it's really because of sinus node dysfunction. So sick sinus syndrome, tachybrady syndrome, and so if you're only going to put a single atrial lead, you don't have any good backup in the ventricle. So you're going to have to depend on the AV node conduction. So the advantage of that, sometimes there is younger population that have just sinus node dysfunction. So you don't want to give someone too many wires where they're still young and they might end up needing 4, 5, 6 generators. So you kind of want to avoid having unnecessary hard wires. So you might use it for younger population that only has evidence of sinus node dysfunction. So because of that kind of limited population is not very commonly used. So who's next on the list? Ahmed Al-Haydar.
ايوه اهلا دكتور.
يا هلا.
كيف؟ There is no clear B wave. There is pacing in atrial and ventricular rhythm.
لحظة نبدأ. So you're saying there is no clear P wave.
Yes.
هذا حنرجع لها بعد شوية بس يعني.
Okay.
So we
If there
start
is pacing,
by.
Doctor,
No,
actually,
so
atrial.
there is an atrial pacing spike.
Yes.
But you don't see any evidence of morphological evidence of P wave.
Yes.
So you rather go over some of the rhythm strips. So there is something here. There is something here. But yani, I agree with you. It's not the P wave that you usually see. So it's not strikingly large. And then we'll continue. You were saying there is paced atria, no P wave.
Yes.
And
there is no P wave, and there is no pacing. There is QRS without pacing before it.
Okay. So ال QRS اوصف لي اياها شوية.
It's a narrow QRS دكتورة. Not wide.
Okay.
And
طيب من فين جاية QRS هذه؟
It's ventricular.
So when you say, okay, when you say narrow, so narrow QRS doesn't arise from the ventricle.
Sorry, from the even it's basing the atrial from atrial.
So either conducted through the AV node or it's coming from the AV node. So it's either junctional or conducted, صح? But it has to pass through the AV node, so because it's narrow complex. So do you think it's junctional?
I don't know. So
okay. Do you think it's conducted?
Yes.
Okay. So هنا, so this is the trick. You don't see very nice P wave. لكن after every single beat, there is a fixed AV delay and there is a QRS. صح ولا لا? Seems that the QRS happening on a regular interval after the paced beat. صح? You indirectly see the atrial capture. You don't see it morphologically on the ECG, but because if there is no atrial capture, there's not going to be conduction to the ventricle. is the electrical impulse just didn't capture the atrium, خلاص it's going to die and nothing's going to happen. صح؟
Yes.
اوكي. انفهمت ولا ما انفهمت؟ أحد ثاني عنده سؤال عليها؟ Okay, I'll assume everyone understands it. So, is this a single chamber device, dual chamber device?
I think most likely it's for a single. There is no ventricle pacing.
زي ما كنا absence of evidence doesn't mean evidence of absence.
Yes, I know. But most
you
likely.
don't. So it's حتى هذه more likely to be dual than single because you're seeing single atrial activity. You don't see any ventricular activity or at least any pacer. But you could have a ventricular lead and it's sensing the ventricle and it's inhibiting pacing. صح ولا لا?
Yes, sure.
Okay, so حتى single chamber atrial pacemaker is rare. زي ما كنت بقول قبل شوية, it's a limited number of population that you would take the risk of putting only a single chamber device in the atrium. So at least, yes, it's behaving like a single chamber device in the atria. At least now it's pacing as AAI mode. I can't definitely say this is not a dual chamber device just because we don't see any evidence of the RV functioning. We're good here.
It's clear, دكتورة.
أحد عنده سؤال؟
دكتورة لميا، مش المسافة ما بين البيسنج تبع الأتريوم والفنتريكل مرة يعني prolonged.
So okay, there is first degree AV block. So what? So and that's why in إحنا we try to make things as physiological as we can. So we want to avoid إذا كانت هذه dual chamber pacing. We want to avoid ventricular pacing. لأن ventricular pacing has its disadvantages. It causes cardiomyopathy, could cause kind of symptomatic pacemaker syndrome, could cause. So you try to avoid that. So you want to have some intrinsic as much as possible. So you could, if you're kind of doing your pacemaker, programming the pacemaker, so you could actually set the pacemaker to work as AAI, and then once there is a dropped QRS, it will switch to ventricular kind of DDD to pace the ventricle to avoid that. And other ways of doing that also is just extending the AV delay. You could extend it up to 300, 350. Some devices you could go up to 450 to extend the AV delay. So you'll also allow the intrinsic QRS to be there. Some people might be very symptomatic when they have a very long AV delay. For those people, you might want to shorten it. The basic thing is you want to minimize ventricular pacing, but also you kind of want to keep the patient as symptom-free as possible. So that's why we don't see any ventricular pacing, but doesn't mean that the ventricular is not sensing and getting inhibited. Okay. دخلنا شوية. Who wants to take this?
Okay, Ahmaduddin, you can take this.
Sure.
Okay. Assalamu alaikum.
Alaikum assalam.
We'll start with the prism strip A2. Okay, spike before the P wave. This is atrial pacing, followed by conducting QRS natively. The PR interval or AV interval is prolonged, keeping with the first degree heart block. Then, hello.
اتفضل كمل يلا.
Then there is 1, 2, 3, 4. In the fifth P wave, there is a drop P wave. There is no QRS after the P wave, or and then it is conducted. Then it is or late conduction, as if it is Winkie-Bach or
Okay, so you're doing good.
yes.
So
Then the next beat is the conducted with shorter PR. Seem to be like Winkie-Bach phenomena, the previous one. TL, I don't know what is a TL.
I just ignore the abbreviation.
Okay. Okay, then also there is the S atrial followed by native QRS, then followed also by fast atrium with prolonged conduction with the AV.
Okay, so I'll just go back here. We'll start. You're doing very good. بس يعني I'll try to put it all together. So هنا عندنا spike followed by P wave. بعدين عندنا ال AV delay is long, so it's almost 240, 80, 300 and something.
Yes.
بعدين the native QRS. بعدين عندنا هنا pacing spike, P wave, very long PR interval, almost close to 400. So the PR interval in the second beat is longer than the PR interval in the first.
Yes.
So it's the PR, بعدين ال QRS. Here عندنا pacer spike, P wave, even longer PR interval.
Yes.
بعدين هنا pacer spike, P wave, even much longer PR interval. Pacer spike, P wave, and then dropped QRS. And then another pacer spike. So this is, if you ignore the pacer spike, PR prolongation. So this is second degree type 1 or Winkie-Bach AV block. صح? So عندنا pace atrial rhythm. عندنا second degree Winkie-Bach.
So this indicates there is intrinsic AV node disease, because the patient might be.
The Winkie-Bach doesn't have to be disease, but there is some.
Okay.
Maybe because it's a norm. Sometimes it's a normal physiological thing, so it doesn't have to be a disease. But there is evidence of second degree type 1 AV block. So let's recap. So pacemaker capturing low.
Yes.
Is it sensing low? احنا نتكلم دحين على atrial lead that's facing the. Is it capturing low?
It is just capturing the atrium, just like the AAI.
Okay. Is it sensing the atrium?
It is, yes, it is pacing.
Okay. Then pacing and capturing low. And this is the first job of the pacemaker. The second is the sensing. Is it sensing low?
Yes.
So on what basis?
On basis that the P wave atrial pacing followed by native QRS. conducted.
طب احنا بنتكلم على الاتria. انت بتتكلم على QRS. I want to assess
إيه.
the sensing of the atrial beat.
Well, it is pacing يعني almost consistently pacing ما في
So I can't comment on the sensing. صح ولا لا؟
yes I cannot
So
unless I have
I
a
can
native P wave.
exactly. So I can't comment on the sensing. So it's capturing well.
Just
Can't
capturing well.
assess the sensing. Okay. Is it a single or dual chamber device?
The single.
عشان
Because it is just consistently pacing the atrium and followed by natively converted QRS. No spike for the QRS. And
okay.
even after prolongation of the
هو
AV,
even after prolongation هذه مو مشكلة. The dropped beats هي هذه المشكلة. عادة because you almost wait for a period of time. لكن because it's only one dropped beat, some devices would ignore that. فهمت علي؟
okay.
زي ما قلنا, we try to make things as physiological as possible. So some devices you could program one drop beat.
One drop beat, okay.
So some devices would allow you to انكباح and have a one drop beat.
And even if I have RV lead, it's allowable to one beat.
Yeah.
Without.
So I agree with you. If you get this on an exam, this is a single chamber AAI pacemaker.
Okay.
لكن just in the background, it still could be a dual. But this is most likely a single chamber device.
Okay.
Okay.
So regarding the AV interval, it's very prolonged. 360.
So yeah,
Even
we could, as we said, we try to minimize ventricular pacing. So the reason we put a device is to minimize the symptoms of the patient without doing any harm.
Okay.
So we're trying to manage whatever the symptoms was. Is it kind of bradycardia, fatigue, whatever? But we try to minimize kind of also the disadvantage of having a pacemaker. Because if you overdrive or if you pace a ventricle too much, RV, as I said, it's a kind of pacemaker syndrome, LV dysfunction. You might get also deplete the battery. So it's not, when you deplete the battery, you might kind of need to operate sooner for generator replacement. So least harm you could do is better.
طب دكتور أنا عندي سؤال.
تفضلي.
That means if we had a long strip, shall we see the same picture repeated every time? Drop beat.
هو إذا كانت ما هو عشان كذا. That's why. So that's why I would think yes, this is most likely an atrial pacemaker. And I can't 100% rule it out unless I know what is underlying device. So, because sometimes, yes, the device would allow you to have a drop beat, but it depends also on the programming. يعني حتى a single chamber device, I could still program a dual chamber device. I could still program it as a single chamber device. So it depends on the programming. But yeah, if you see something like this, there is some AV conduction there is some AV conduction block. So you want to assess why is that? So are the patients on medication? Are the patients on only a single lead? Do we need to change the device? So you should try and figure out why there is winkebach. But it still could be a normal, but that's not the first thing you would say. You would say it's a single chamber device. And then you would see if you need to kind of add another lead or activate the RV lead.
تمام.
Next, can dual chamber pacing. So dual chamber pacing, you have a lead in the ventricle and lead in the atrium. So you could change the setting of each lead separately. So you could A sense and V pace, or you could A pace and V pace, or you could A sense and V sense, or you could A pace and V sense. You got my point? So you could pace either in the ventricle, pace either in the atrium or ventricle, or you could sense either in the atrium or ventricle. So it depends on what is the underlying disease, if it's sinus node dysfunction, is it AV block, and things like that. So who wants to take this? Next on the list, any volunteer?
Yes, I will take it.
Okay, go for it.
Okay, if we look at the strep rhythm and the lead to down, we can see there is a spike before P wave, and then we have a P wave, then a spike before the QRS complex, which conducted to the QRS, and then this is repetitively happened in the following beats. So I would say we have a spike before atrial activity, which capturing, and spike before ventricular activity and capturing. So maybe we have here dual chamber pacemaker, and I think it's well functioning because I cannot see like any I don't know, is that correct?
Yes, I agree. So so there is dual chamber device.
Yeah.
There is both atrial and ventricular sequential pacing and capturing. Can't assess sensing. إنه ما في أي intrinsic, so we can't really see what the device is doing to intrinsic.
Mm-hmm.
So I agree with you. أي أحد عنده سؤال؟ Okay, next. Okay, أكمل باسم.
مرحبا دكتور.
يهلا. So.
طيب, to me, I will look for long strip and lead flow. To me, it is dark amber. It is when there is atrial and ventricular pacing. And I think it is functional. Dove chamber pacing, functional dove chamber pacing, doctor.
So when you say functional, اشرح لي what do you mean functional?
Functional meaning every B wave it is pacing and QRS it is pacing also.
برضه ما شرحت لي إياها كويس. So we talked about pacemaker function. There is good sensing and there is good capture, صح?
Yes.
I think there might be a problem with the connection. إذا مو سامعيني let me know. There is atrial pace and then there is capture. So for this beat, we're assessing the capture. So there is good capture. There is atrial pace, spike, and then capture. Like, and if you go to the one, almost the last one, so there is a spike, but you don't see the P wave. So I think this might be loss of capture at an atrium. And you could see the P wave very well in the previous
دكتورة عفوا
complexes before.
yeah.
So the last one here, so there is loss of atrial capture. So that's one. Could we assess atrial sensing?
But if I compare to the other, the last beat, if I compare the CRS of the other above, I think it is basing in before the Torah.
And I don't see any P wave. But the idea in here, this one definitely looks different. All the remaining previous ones, you could see some atrial activity. This is the only one that I don't see any atrial activity. That's why I think there is some loss of capture here. So for the atrial sensing, so for sensing, as we said earlier, there has to be an intrinsic atrial activity, and then we'll see how the device behaves on it. So at least for now, there is no evidence of intrinsic atrial activity, and there is no evidence that the device is behaving inappropriately to a noise, for example. So we can't comment on sensing, but there is some atrial loss of capture. So بالنسبة للventricular lead, so there is a pacer spike and QRS, pacer QRS, pacing QRS till the end of that. So there is good capture, but I can't really comment on the sensing. في أحد عنده سؤال عليها؟
دكتورة لميا ممكن أنت
تفضلي.
قلتي ما نقدر نعمل كومنت على السنسنج للفنتريكل.
نرجع
بس قصدي
what is sensing? What is sensing?
لا أنا قصدي دكتورة مثلا بليد 1 عندنا سبايك للأتريوم وعندنا سبايك للفنتريكل، بس لو رحنا الليد 2 عندنا بس باين سبايك للأتريوم والفنتريكل ما في سبايك. فما أدري.
Spikes doesn't have to be the exact same morphology in all the leads. لكن this is definitely a spike. معناته this is a spike. معناته هنا في spike. You don't see it in lead 3 بس مو معناته إنه that's not a paced one. Just because you don't see a spike here, you follow it from the other leads. You could see something here, you could see something here. Then you follow it down. So this one here, there is something that resembles a spike. It doesn't have to be the same exact thing in all the leads. This is the ventricular QRS that's generated by the paced ventricular output. Shall I move on ولا في أحد عنده أي سؤال ثاني؟ Okay, so what is the difference between a pacemaker and an ICP? بس هو عشان هذه الصورة فيها something that might tell you the difference.
The shock coil.
The shock coil. So
on the side of the can.
هذه it's not the difference between the pacemaker and ICP. So and then the lead, the shock coil is right. And how many shock coils do we have?
Usually it is depend if it is a single I have one shock coil. If it has a dual atrial and ventricle, have two shock coils.
Atrial and ventricle?
it depends if it's a single chamber ICD or dual.
So احنا
Usually
نتكلم على shock coils.
shock coil
What
when
are the shock
usually
coils for?
for usually in the ventricle for the shocking VCAT or SVT very very fast.
Okay, so the shock coil is for shocking the ventricle in case of malignant ventricular arrhythmias. So the shock coils is attached to where?
So RV lead. Tips of the
Okay.
RV lead.
So, okay. So, and how many shock coils do we have?
Usually one in the RV.
Okay, usually one, but how many could we have?
We have two.
Okay, and what is the other shock coil?
Usually in the RA. Second
So
one.
it's not the RA, it's called SVC. So it's usually in the SVC. So
okay.
Hina, this is just a drawing. So if you could see the devices here is going down to the SVC, and then the right atrium crosses the valve. And after it crosses the valve, you could see that there is more radio-opaque dense at the end of the lead over here. And then here is the tip of the lead. So this kind of long, opaque, dense stuff is the shock coil. So the energy is delivered from the battery through the device into the through the lead into the shock coil. So this is the direction of the energy from the can to the coil. Sometimes, or that used to be the standard of practice, but not anymore. If people fail this shock, you might need to add another coil, and that is usually in the SVC. So that will be able to absorb energy or deliver energy. So it might increase the defibrillation surface area and deliver more energy to the heart. But because the need for it is minimal, and some of the disadvantage from an SVC coil is the obstruction around the SVC or the adjacent veins, and also fibrosis that might make a lead extraction difficult. So it's not used as often as it used to be anymore. So the other thing, I think Mika and Ahmad can tell him. The other thing, some people who have paroxysmal atrial fibrillation, they used to have an atrial defibrillator. So there is a coil attached to the atrial lead, and they would be instructed on how to activate a shock from their device. So they will stay at home, take a little bit of kind of benzos just to relax them a little bit, and they could deliver a shock from themselves. But also that's not used anymore, so as to deliver a cardioversion from themselves. Okay, so this is a small diversion. So what is this lead? There is an arrow here. إيش هذا؟ ما في volunteers؟ مين
Looks RA sorry كانت
sorry
seemed كانها LV leads يعني shape not typical size يعني.
هو عشان كذا أنا عندي السؤال. It's not something is here بس إيش هو؟ That's why you need to follow the device.
there is a 2 lead from the device or 3 lead عفوا.
في 3 lead طالعين من الديفايس.
إيه.
I see 1.
2 1
Where's the second one? There
are
is
two tips from
there is
yes,
2
it's
screws
one
here.
and above one. It's 2 screws. Yes.
There are 2 screws على الheader of the device. لكن how many leads are coming out of the device?
Yes, one lead.
Okay. صح? 1 lead.
So this may be
And you
a cap
follow
lead.
it. If you follow it, it's going all the way to the RV. وهذا عليه shock coil. صح؟
Yes.
Okay. So إيش هذا؟
Capped lead.
هذه seems to be على the same lead. صح ولا لا؟
صحيح.
Okay. What is that?
In the RA, maybe?
So it's in the RA. You're right. So هذولا are extra electrodes. If you look at this is the lead. So those are extra electrode that is attached or on the lead when the lead is in the atrium. So what do you think those electrodes is going to do? It picks up signal. So a pacing, you don't have enough contact with the myocardium to be able to deliver that sufficient amount of energy. And they're on the lead, but you're not attaching it. لكن they're in the atrium, but they might be able to sense the atrial signal. فهمت علي? It's high in the atrium, so you're trying to be closer to the sinus node to be able to sense an atrial signal.
Okay.
Okay, so this kind of lead, you could sense the atria and you could pace and sense the ventricle because the tip of the lead is attached to the ventricle. So you might utilize that as part into a dual chamber device. So that's why here you see more than one. فهمت علي؟ لأنه those are connected separately into an atrial screw and an atrial slot, and you could only use it for sensing.
Interesting.
So, for example, if someone has AV block, so you could sense the atria and deliver ventricular pacing without the need of putting a separate atrial lead.
Okay, interesting.
So there are some kind of modes kind of related to that. So when we talked about the common modes, the less common mode is you could only sense the atria. So you're facing the ventricle in here, but you're sensing the ventricle and atrium. Okay. So the first letter is going to be V. The second letter, VDD. Exactly. So this is how usually this lead works. So you could only program it as VDD because it doesn't have any pacing capability to the atrium.
Okay.
بس آخر كلمة على المagnet mode. So for the magnet, مكتوبة هنا, when you put a magnet on a pacemaker, it's gonna pace asynchronous pacing. إيش يعني asynchronous pacing؟ يعني it's gonna ignore any underlying rhythm and it's gonna pace whatever chamber the device has. If it's a single chamber, it's gonna pace that single chamber. If it's a dual chamber, it's gonna pace both chambers. at the specific magnet rate. So for each company, they have a different magnet rate. So you don't have to know it. So if someone is going to going to surgery and they're calling you because this patient has a pacemaker and does it need adjustment before going to surgery? So what information do you want and what information you're going to tell the operating team? عندي هنا دكتور محمد. دكتور محمد ولا دي محمد I don't know مين هو دكتور ولا. طيب next إذا هو مو راضي to answer iPhone. في أحد iPhone لحاله. مين هذا؟ iPhone. Okay. دكتور ناصر.
Yes.
Okay. So we're talking about someone called you from a surgical team. They're telling you need to take this patient to the OR. He has a pacemaker. Advise us what to do.
First of all, we should to call the company for the magnet operation to adjust the heart rate and to minimize the rate of the if there is any ablation or anything to minimize the time. We'll fix the heart rate for regarding the atrium and regarding the ventricle. Will depend totally on the pacemaker. Will not depend on the sensing at the stress or OR.
Okay, so there are multiple things that we need to talk about. One, first of all, patient has a pacemaker doesn't mean he's pacing all the time. So you ask them.
Yes.
A little bit intermittently, so we don't need to do anything for the device. So number two
دكتورة
is
الصوت يقطع ما سمعنا response.
okay. I was saying that if the patient is not paced على المونيتور ولا على ال ECG, that means he's not requiring a high amount of pacing. So you don't need to adjust the pacemaker since he's not using it most of the time.
Okay.
So why do we all do all of this adjustment? One is we're afraid that if you're going to use cautery, that the electrical signal from the cautery is going to create some noise around the device, and the device is going to see this noise and sense it as electrical signal coming from the ventricle, and it's going to inhibit pacing. So for that to happen, you need the patient to be pacing for a lot of time, and you need to have the cautery on for a very long time. So, and that's why when you think you want to adjust the pacemaker. So if the pacing is not going to be all the time, and the cautery, very, very unlikely that this surgeon is going to use cautery all the time. So the amount of cautery is minimal and the amount of pacing is minimal. So you don't really need to adjust that pacemaker setting. واضحت?
واضحة.
So the second is when you get, okay, no, this patient is dependent or he's pacing a lot of the time. So you want to avoid inhibition of pacing during cautery. So at that time, you need to adjust the pacemaker setting. So what are the modalities that you're going to adjust the pacemaker setting? So if you're during the night, you need to take him to urgent surgery. You don't have the facility of getting the programmer and analyzing the pacemaker and changing the pacing mode. The easiest thing and the quickest thing is to put a magnet on the pacemaker. Any magnet would do. It doesn't have to be the company specific magnet. So any magnet would do. It will make the pacemaker to pace at asynchronous mode. So it's going to pace the atrium or the ventricle at, for example, 80 beats per minute or 90 beats per minute. That's the magnet mode. But the tricky thing about it, because you're going to have to keep it over the device all the time. So if you're transferring patients from one place to another place, if you're doing some changes in the OR, for example, ortho surgery or things like that, so you're not 100% sure that the magnet is going to stay in place. So, but that will give you time to get the programmer, or if the patient, or if you have a programmer and the cases are not urgent, you could actually do that. So you would change the pacing mode into asynchronous mode. So what is the asynchronous mode that you're gonna program the pacer at?
VOO.
Exactly. So VOO is a Canet single chamber device. DOO is a Canet dual chamber device. But also you could change a dual chamber device into VOO. If you only want to pace the ventricle, you don't need to overdrive pace the atrium. Okay, so what does a magnet do in an ICD? This patient has a pacemaker. This patient has an ICD. What's the difference? El magnet.
I think if there is a VT storm, it is going to stop the shocking of the ICD, the shock basically.
So it will disable shock.
Yes.
Okay, so you're going to disable delivering shock while the magnet is on. So I wouldn't say in someone in VT storm, you need to disable the shock. I'm saying someone in VT storm, you need to manage the patient, avoid excessive shocks, but doesn't mean if the shock is the only thing that's going to treat the patient, you're disable it. Antalya?
Sorry. Yeah.
I wouldn't disable a shock. I would try to maybe make it delay it, see if there's anything else. Let's say any shock in someone who's incessant VT or a VF. It's not, it's actually more of a life-threatening emergency. So the next, it will disable shocks. بس خلينا نقول this patient, for example, is requiring pacing. So what does the magnet going to do for that?
An ICD?
An ICD, yes. احنا قلنا عادة المagnet will make the patient pace in an asynchronous mode.
I think it doesn't affect the unless the patient is pacemaker dependent. Because ICD is the backup pacing, right?
خلينا نقول احنا نprogram it at عند dual ICD, we program it as DDD. Sorry, مو he has, let us say, AV nodal disease after whatever surgery and had a CRT implanted, and he's pacing from his CRT, and which is a CRTD. So he's requiring pacing from his device.
I think
and he's So you would put a magnet and tell them, don't worry about bradycardia. The magnet is going to pace asynchronous.
Yes, I will not put a magnet in CRPD because it's, especially if
Okay, so the magnet in an ICD works differently. So one, it inhibits therapy. So for example, this patient is going to the surgery. If you use cautery, the device is going to see it as noise. It's going to be very close to each other. So it might count it as ventricular signal and might diagnose it as VF and might give inappropriate shock. So you want to disable therapy so the patient will not get shock from noise from the cautery. Okay, so this is the different thing. So the magnet in an ICD doesn't affect any pacing function. So as you said, usually, the magnet, ICDs are backup pacing. So when we put a magnet on it, it wasn't required to pace because pacing is very minimal function of the ICD. لكن that's why the magnet wasn't programmed to do asynchronous pacing. So if this patient is pacing dependent, for example, after valve surgery and aortic valve surgery has some sort of AV block, hapatlo CRT-D. So you need the magnet to disable therapy, لكن you need something to make him pace asynchronous during the surgery. So للأسف, the only way to do that is you need the programmer and you need to change the setting to DOO for it to be asynchronous. So magnet for pacemaker is asynchronous pacing and magnet for ICD is disabled therapy. So that's the difference between both of them. Any questions? هو في أشياء ثانية احنا ممكن do an extra session بالنسبة لل troubleshooting اللي هما over sensing, under sensing هذه الأشياء. An extra session if you want to go over it. And a few examples out of ECG. But I think we're done with the magnet here.